Good morning. We're soon starting the Padma Shri Tony Fernandez Video Award session. Myself, Dr. Sudha and Dr. Rosemary will be conducting the session. So please be seated. Now the award session has been a difficult choice. We had around 33 videos and they had to be seen and arranged, and out of this, the best 7 have been selected and will be announced. The presenting author has to be here when it is announced, and we have found it rather difficult to find out the best because very, very close marks. So congratulations to all the winners, and we have a great panel of judges. Dr. Rosemary, please.
Padma Shri Dr. S. Tony Fernandez Video Awards, Drishti 2025. Dr. Tony Fernandez has undoubtedly been instrumental in fostering ophthalmology in Kerala, and he indeed has been a main pillar of putting ophthalmology of Kerala on the national map. So this video award session, instituted in his honor, is a contest that is very valiantly fought every year, and as ma'am rightly said, we'll be calling up the final 7 video awards for the final judgment on stage right now. And to judge these videos, we have an equally impressive array of judges, and we would like to introduce to the audience Dr. Namrata Sharma, AIMS, Chairman, Scientific Committee, AIOS, Dr. Naresh, VR Surgeon, Aravind Eye Hospital, Dr. Prashant Bavankule, VR Surgeon and Chairman, ARC Committee, AIOS, Dr. Fairuz, Oculoplasty and Onco-Surgeon at Horace Eye Care, Bangalore, Dr. Charles Karia, Professor, Amala Medical College, Thrissur, Dr. Prafulla Kumar Maharana, Cornea and Refractive Surgery Specialist, AIMS, New Delhi, and Dr. Mohan Rajan, Rajan Eye Care, Chennai, President-elect, AIOS. All these judges have proved their own mettle in their own fields, and we are proud to have you to judge the final 7 finalists of the Padma Shri Dr. S. Tony Fernandez Video Awards. And we would like to invite every chief author, as they are called, onto the stage, and to do the honor of announcing the first final video award of the day, I would like to call upon Dr. Sudha ma'am.
Okay, the first video, this is not being called in any order, but I'd just like to introduce the first person, the first video we have selected for presentation. So judges have to come. Can you wait for 5 minutes? Or should we start? Okay, 5 minutes.
As we wait for 2 of the judges to please take their seats here, I would like to introduce to the audience that none of these finalists have been informed beforehand of whom they are. So we hope that all 30 plus videos that have been submitted, the chief presenting authors are present here. And as your names are announced, we would like to invite the chief author to come and present the video on stage. And the scientific committee has very specifically commented on the content of videos that were obtained this year. Videos, we all know, takes a lot of effort, takes a lot of time, and for presenting it for a video award session, it always tells us what new was done. What new was done in the clinic, in your practice, in your hospitals, in your life. So, and Dr. Baston sir, the chairman of the scientific committee, very specifically wanted to say that this time the competition was so tough that he said, I can even give you the mark list. Certain videos didn't make the cut for barely a fraction, 0.2, 0.1. That was the margin that was. So all 7 of the final videos should be very proud, and all those who don't make it should be even prouder. And for the final cut, I'm sure the judges will have a difficult task at hand. And as the judges arrive, we have all 7 of them taking the seats, and we'll be shortly calling upon the first presenting order.
Welcome, Dr. Prashant. Please come.
We have
Dr.
all
Namrata,
the
please.
all
Welcome.
the-
Welcome, Mohan Rajan, sir.
we have all the judges here and a few of our esteemed invited faculty. Before we start this session, I would request our President, Dr. Raji Sukumaran, to hand over the mementos to our very important people. First, our dear Scientific Committee Chairman AO is Dr. Namrata Sharma. Next, ARC Chairman, the energetic, the youthful Dr. Prashant. Next, we have two wonderful people from Gujarat who are actually going to organize the AOC in the year 2027, right? Yeah. Dr. Divyang. No, he has taken. And Dr. Jagdish Rana is going to be the organizing chairman, organizing secretary, yeah, chief organizing secretary. So, if you want anything from Ahmedabad, sir is here.
So thank you, Dr. Shri. Yeah. So welcome to the session once again. So we start with the first video. This is again, as I'll just specify, this is not in any merit order. This is just random. But I'd like to introduce the first.
Our dear Vice President, Dr. Mohan Rajan, wants to felicitate.
My student, he is so proud of Rajiv.
I'm taking. I know you can't do without a photograph, so I had to.
Yeah, sorry.
Okay, we call upon the first video. Video number 5, Dr. Matthew Joseph. So presenting author, please come on stage. And I would like to say that I'm really honored, and Drishti is really honored to have this video. Though it may not be made for an award session, it is a beautiful video by a beautiful person. And exactly what the spirit of this video is what we intend for Drishti. So please welcome Dr. Matthew Joseph, sir. Please Start the video. Yeah.
Friends, I have made an echolocator to help blind people using ultrasound, which mimics the mechanism used by bats to navigate in total darkness. This is the sound signals produced by bat. And this is the signals produced by my echolocator. 2 years back, during a meeting of the Kollam Ophthalmic Association, an interesting paper was presented on the latest products available to assist people who are completely blind. Most of them were innovations on the white stick which the blind currently use. They were mainly additions of ultrasound emitters to the sticks which produce vibrations when there are obstacles in front. The blind person can then feel the vibrations on his or her hand. A few were more advanced, which the blind person wears and tells as audio about the obstacles. After going home, I thought of bats, that is Vavval in Malayalam, which are nearly totally blind, but can fly at high speeds in total darkness, avoiding trees and branches to find food like fruits, insects and small animals. I found that bats are able to clearly make out even an insect sitting on a leaf. Bats make ultrasound waves from their mouth, which are reflected from the surroundings and are picked up by the bat's ears. These are then processed in its brain to form images. Like light waves in eyes, sound waves in the ears are converted to electrical impulses and processed to get the sensation of hearing. I also found that the brains of all mammals are essentially similar. Blind people are many times more sensitive than us in other senses like sound and touch. That is how they are able to read the braille. So I thought whether we can provide to the blind the same mechanism as bats use for vision. A completely blind man in the US named Daniel Kish has developed a very effective method of navigating by making clicking sounds with his tongue. He trains even young people this technique. They are able to even ride bicycles and skateboards with this mechanism.
We found other people possessing superhuman powers. Daniel Kish is like the superhero Daredevil, who's blind but uses heightened senses to fight crime.
This is from the movie Srikanth, where he is thrown out of the blind school without his white stick. He then navigates using clicking sounds with his fingers. First I experimented with the car reverse sensor. I found it worked, but its range is very limited, only about 1.5 meters. Then I read about the bat detector, which is an equipment used by bat societies in England and USA. This instrument picks up the ultrasound emitted by bats and converts them to audible sound which we can hear. I managed to get 2 of them through my daughter from abroad. Next problem was making the ultrasound transmitter with a range of at least 5 to 6 meters. Father Ferdinand Peter, former director of Benziger Hospital, and at present the director of Radio Benziger, got me in touch with Mr. Nishant, an excellent electronics expert. He made the appropriate circuit for the transmitter with a 6 to 9 meter range. Here the spectacle is oversized because it was made by 3D printing, but not to scale. The ultrasound transmitter and the receivers are mounted on the spectacle frame which the blind man wears. In the center you can see the transmitter which emits the ultrasound waves. The transmitter has its own processor. On either side are the receivers, one on the right and one on the left. The ultrasound waves are processed and converted to audible sound waves in the small box the blind man wears around the neck. The blind person hears through earphones. I presume that, like in our eyes, the reflected sound waves reaching the right and left ear would be different. That is why I provided a separate processor for right and left receivers. The blind person can then combine them to get a 3D effect. In the following video, you can make out the difference in the echoes as the spectacle is turned towards different objects. This is the spectacle which the blind person wears. And in the center you can see the small circle. This is a transmitter which emits the ultrasound. And the reflected ultrasound waves are collected by these two receivers. Now these are processed in this small box which the blind person wears around the neck like this. It's a simple mechanism. And then ultrasound waves are then processed and converted to audible sound, and then the blind person hears them through the earphones which he wears. We have tried it on some blind people with very encouraging responses from them. We are hoping that kind-hearted people or organizations will come forward to produce and provide these echolocators to the poor blind at subsidized rates. You will agree that this is not a profit-making venture, but purely philanthropic. The poor blind need our kindness and help. Let us not forget that India has the largest number of blind people in the world.
Thank you, sir. And I think we all need to really give applaud this sir for at this age. He's actually, the spirit is what counts. Thank you so much, sir. And since we don't have much time, I'll just like to ask Dr. Mohan Rajan to please comment upon this.
Sir, you've always been a role model and inspiration for all of us, and today you proved it. And age is just a number, sir, and you, fantastic. I'm really fascinated by this technology, and whatever you have done, and you have done it, it's so simple and elegant, sir. I think hats off to you, sir. My salutations to you. Thank you.
Sir, I would request as a chairman of ARC-IOS, why don't you put it for our Think Under the Apple Tree Innovation Award we have on behalf of AIS. I would request you to put it so that that will be a good thing.
Sudha, I'm taking 1 minute only, I'm not taking much. He's from Kollam. When he first told this to me, I said, you present it as video. Otherwise, he would have kept it to himself.
Yeah. Thank you, sir.
We would like to call upon the second video of the day, video number 20. We invite the Chief and Presenting Author, Dr. Anna Kurian Mullasheril. And if she is absent, we would like to invite on her behalf the co-author, Dr. Ani Sridhar ma'am. Video 20.
Artistry behind every block, the hidden craft of oculoplasty. Every blink tells a story of vision and identity. For the child with an eyelid growth, for the young man seeking cosmoses, for the woman scarred by trauma, for the elderly losing function to time, oculoplasty restores more than form. Every incision begins with imagination, from choosing the right instrument to learning a discipline that millimeters make meaning and shapes not just appearance but confidence and life itself. Each curve, each contour, blending seamlessly with the patient's unique features. The beauty of the Fernandez silicone sling lies not only in its technique but in its transformation. A single strand of silicone, guided with care, bridges what the eyelids cannot achieve on its own. Lifting the veil of ptosis. The steadiness of cautery defines the art of levator recession. Never hurried, never unsure. With each careful application, balance is restored. The beauty of the theatre of incision lies in its invisibility. A doorway carved within nature's own crease, each gentle punch, an act of quiet strength. It is not destruction, but creation, a channel for tears to flow again. With lid keratinization, every blink causes pain. The eye's soft surface meeting a hardened edge. With the removal of scar tissue and the placement of a mucous membrane graft, the lid is softened. It is nature's gift of renewal. The supple replacing the rough, the smooth replacing the scar, transforming each blink from friction to flow, from discomfort to relief. Plexiform neurofibroma is a burden carried not only on the eyelid but on the spirit of a child. After careful eyelid measurement and comparison with the contralateral eye, skin markings are made. In debulking, each cut is an act of release, lifting weight and reshaping identity. Here, the surgeon is a sculptor and a healer, giving back not just the form of an eyelid, but the dignity of a gaze. The anterior orbitotomy is a window into the hidden depths of the orbit. Within lies the cavernous hemangioma, silent, encapsulated. With cryo, the surgeon lifts and delivers the tumor whole, untouched, unharmed. The intracorneal space is a place of mystery and risk, where vital structures lie in close embrace. Here, the surgeon's role is more than technical, to navigate a path millimeters wide and to emerge with both vision and trust intact. This is a moment where precision meets restraint. The placement of an artificial eye is restoration of identity, the healing of a wound, both seen and unseen. When a face lights up, when a person sees themselves again in the mirror, this is the silent triumph of oculoplasty.
Thank you, Dr. Ani and team. Fairuz, it is a poetic presentation to an artistic surgery. Kindly come in, please.
Yeah, excellent. Very impressive video, and I think the voiceover was as calming and artistic as the surgeries were, and sharing the same speciality with Dr. Ani. Oculoplasty, I believe, is definitely an artist's job. If you have art in you, your voice in hand, I think the outcome is amazing. And as she said, we always relate oculoplasty to aesthetics and beauty, but it's more than that. It's about vision in many cases. It's about the confidence and, the mental well-being of a patient. So that is what we as oculoplastic surgeons do, and that is very well showcased in this excellent video. Fantastic. Congratulations, ma'am.
So it was done by my fellow. So I didn't even know actually that she wanted to do it.
You were the guide.
We would like to call upon the third video of the day, video number 22. We would like to invite the Chief Presenting Author, Dr. Shebin Salim, onto the stage. Dr. Shebin Salim.
The road to rehabilitation.
Rehabilitation of a not-seeing disfigured eye with a visually appealing prosthetic eye is not just a cosmetic solution, but a key factor for successful social, occupational, and psychological well-being. Need for cosmetic rehabilitation can be either congenital or acquired. Congenital causes includes anophthalmos and microphthalmos. Acquired causes may include status post evisceration, enucleation, or exenteration. Causes of corneal opacity with nil visual potential and phthysical eye. A thorough evaluation is done before choosing an appropriate method, including detailed clinical examination and appropriate imaging in selected cases. Methods include cosmetic contact lenses. Cosmetic contact lenses type B and corneal tattooing can be considered in patients with corneal opacity, especially when anophthalmos is less than 2 mm. Inocular prosthesis is used in patients with a phthysical eye or after enucleation or evisceration. It replaces 25 to 30% of the orbital volume. These prostheses can either be prefabricated, such as scleral shell or stock shell, or custom-made prostheses. Additionally, there are exenteration prostheses which are used in patients who have undergone exenteration. A customized prosthesis is fabricated for each patient, hence it will be having a better fit, motility and color that also matches that of the other eye, giving an excellent cosmesis.
The alginate impression of the socket. An impression tray is selected according to the patient's socket size and inserted in the socket. A measured amount of alginate with 10 ml of water is mixed into a flowing paste, loaded into a 10 cc syringe and into the impression tray, which is kept ready in the patient's socket. The alginate paste fills the entire sac and starts penetrating through the holes of the tray. Once this alginate is set, the impression tray is gently removed from the eyes. A plastic tumbler is half filled with water and alginate is taken and made into a paste. The impression tray is immersed into this paste and allowed to set. Once it is set, the contents are taken out into 2 halves and the tray is removed. In a wax ladle, carving of wax is heated and poured into the hollow space left by the original tray and allowed to set. After 15 minutes, the halves of the alginate are opened and the set wax is taken out to form the wax mold. Carving the wax. Once the wax mold is ready, an aluminum corneal button of the fellow eye size is taken and placed on the wax model. The wax is smoothened by carving with a scalpel, blade and hot flame. Once the wax model is perfect, plaster mold. Plaster of Paris and dye stone powder in a ratio 3:1 along with water is made into a paste. This paste is filled in an eye flask up to the rim. Then wax model with the corneal button is placed in the flask and allowed to set. Again, the plaster is mixed and filled into the other half of the flask. It takes about half an hour to set, and once it is set, the corneal button along with the wax is scraped out. Now the plaster is ready for acrylic casting. In a short glass, white PMMA powder is mixed with monomer liquid to form a dough. The white PMMA mixture is placed in the plaster mold and the 2 halves are put together and placed in the bench press so that extra plastic leaks out. This is placed in the water bath for 45 minutes at 100 degrees centigrade. Once the curing is done, the scleral shade plastic is taken out, stem of the corneal button chipped and the surface smoothened. The scleral painting is done. clear acrylic is prepared. Once the dough is formed, the clear plastic is placed in the plaster mold. This is cured for 1 hour in 100 degrees centigrade water bath. Once the curing is done, the cast is removed. Then the shell is smoothened and polished. Now the artificial eye is ready for delivery.
Journey doesn't end with just fitting the processes. Processes needs to be taken care of, and yearly polishing is mandatory. The processes needs to be cleaned once in 2 to 4 weeks. A protective glass made up of polycarbonate should be used to protect the normal eye at all times. So how early is too early? In congenital anaphthalamus, conservative treatment using progressively enlarging conformers should be started as early as possible within weeks after birth.
Picture अभी बाकी है मेरे दोस्त.
Everything is not black and white. Cosmetic rehabilitation is complicated by varied problems including contracted socket, prosthesis, implant-related complications or eyelid abnormalities. So each of these needs to be corrected with appropriate techniques and surgeries. To conclude, loss of an eye or vision is not the end. It is just a beginning of another journey. Know the options available for the best care for the patient. Thank you.
Thank you, Dr. Sherwin. For, I think, very useful for postgraduates. Dr. Prafulla Kumar, I saw that you are very interested in the video. Kindly comment, sir.
No, I like the in-house innovation to reproduce such cells. And I think if you can get a patent of it and bring it to the industrial scale, that will be great. Nice video.
So the crux when you get a patent is don't present, because if you present, somebody takes away the idea. So patent it first and then present it. I mean that is the order that you should do. But having said this, I think you should go ahead with the patent. Thank you.
Thank you. Thank you. Can I just, I just want to kind of convey a message. So this is usual work done by ocularists. So it's not an innovation, in fact. So this is the regular ocularistry work that happens in ophthalmic plastic surgery centers. Yeah, so yeah, very nice. Thanks for showcasing that. Thank you.
Thank you. We would like to call upon the next video for the day, video number 24. We would like to invite the Chief and Presenting Author, Dr. Mridula Gangwar, on stage.
Welcome you all to this video presentation. As the topic suggests, sometimes the first surgery is not the final one, and we have to reconsider the surgery for better outcomes. We have no financial interest for this video, and all the interventions shown here are done at Chaitanya Eye Hospital and Research Institute, Trivandrum. Revision surgery in failed primary vitreoretinal cases addresses the challenge of persistent or recurrent disease after an initial operation. Despite significant advances in vitreoretinal surgical techniques, some patients experience anatomical failure or suboptimal visual improvement following primary procedures. So here in this video, we are illustrating various retinal redetachment case scenarios of such interests. This video shows the enduring value of time-honored techniques in such cases. We have highlighted critical steps, technical pearls, and strategies for managing intraoperative and postoperative challenges to optimize the anatomical and visual outcomes. Let's begin with various case scenarios where primary surgery was unsuccessful and later resurgery attempts with optimum tamponade showed favorable outcomes. This introduction sets the stage for discussing specific techniques, outcomes, and challenges of resurgery. In this case, a 62-year-old gentleman with 6/9 parts vision in his right eye. Primary vitrectomy done with C3F8 tamponade, presented with redetachment after 1 month. Thorough peripheral vitrectomy done. That may be a cause for secondary changes and traction. All the persisting membranes removed with forceps. Subretinal fluid is drained through marked drainage retinotomy and pre-existing retinal break, followed by fluid air exchange with continuous fluid aspiration. Endolaser done around all the retinomes and breaks. Pre-existing laser marks are also augmented with endolaser. Cryotherapy done at all suspicious areas of peripheral breaks. Internal tympanating done with silicone oil. After 1 month of revision surgery, thick ERM was noted with poor vision. In RE surgery, at first, silicone oil was removed, followed by removal of all the epiretinal membranes from the macula with the help of pick and cutter. Further augmentation of endolaser is done. Internal tympanating done with silicone oil. In post-op pictures, you can see well-attached retina and macula. Here, a 39 years old lady diagnosed as optic disc pit maculopathy in left eye. On OCT shy tick edema, seen with large SRF drainage, ILM tuck-in with gas injection done in primary surgery. After 3 weeks, inferior RD was seen involving the macula, drainage retinotomy marked and thick SRF drainage done. PFCL injected to flatten the macula, followed by fluid air exchange with continuous fluid aspiration. Endolaser done around all the retinomes and breaks. Thick band of endolaser is done 360 degrees. Internal tympanating done with silicone oil. In post-op OCT, well-attached retina is seen. In next case, 70 years old, seen with extensive advanced diabetic disease and TRD. And after 2 months, large macular hole seen with attached retina. In resurgery, silicone oil removal is done first, gliotic membranes also seen. All secondary membranes at macula are removed with forceps. Pre-retinal heme is fluted and massaging of hole margins done with soft tip. Bleeders endodiathermized, followed by peripheral retinectomy for shy tick retina with gliosis. Margins of retinectomies are marked with diathermy and endolaser was done. Complete fluid air exchange was done with thorough aspiration. Margins of macular hole is fluted with multiple aspirations to approximate the hole margins. Peripheral breaks fluted to aspirate any collected fluid and endolaser is done. Silicone oil injected and you can see type 1 hole closure with good visual recovery. The take-home message for this video is that we should do thorough peripheral vitrectomy and secondary membrane removal. Addressing all drainage retinotomies adequately with optimum tympanating should be done. Thank you so much for your kind attention.
Thank you. Naresh sir, you must have seen a lot of such cases at Madurai. Please.
I don't know whether it's a compliment or otherwise actually. Nobody wants to see nobody wants to see the resurgeries in their surgery, irrespective of whether you are posterior or anti-segment. I think everything was fine. Only thing is slight concentration on the quality of the video, but the last slide was a self-goal actually. In the sense you said you have to do a peripheral vitrectomy completely. You said you have to laser all the retinotomies. You mean to say that you have not done all those things in the first surgery? Yes. So that was the self-goal actually. So you have to be careful in writing your take-home message. Otherwise it's good. Thank you.
So with that, we call upon the 5th video of the day. Video number 18. From glare to relief, we would like to call upon the presenting author, Dr. Vanishri Mahesh Nayak.
This is a case of a 65 years old male who presented with a long-standing traumatic mydriasis cataract with suspected zonal dehiscence. His visual acuity was 6/36, not improving with glasses. He had complaints of glare and disturbance in bright light. OCT showed a thin ERM on the macula, and the biometry revealed significant corneal astigmatism. Now, if only the cataract surgery is planned, the patient will not benefit much because of a large pupil causing suboptimal visual recovery and post-operative care. So I thought, let's tackle the cataract with phacoemulsification. The regular astigmatism can be tackled with the toric IOL, and the large mydriasis can be tackled using single-pass 4-throw pupilloplasty. I begin the case with the toric marking, the side port incisions, and initiate the capsulorhexis with my 26-gauge needle cystitome. I change over to microrhexis forceps to prevent any stress on the zonules which were suspected to be weak. I change over to the other hand and complete the rhexis. I make the main wound into a gentle hydrodissection, gently rotated the nucleus to ensure that it is free from the capsule. I began phacoemulsification with the stop and chop technique, divided the nucleus into 2 equal halves. Then I did the sub-chopping using the vertical chop technique to make smaller pieces in both the heminuclei. Each of the small chunk was pulled out of the bag and phacoemulsified in the iris plane. Once the phacoemulsification was complete, cortex aspiration was done using bimanual technique. The cortex is pulled towards the center gently to prevent undue stress on the zonules. I decided to implant a capsular tension ring to give support to the bag. A single piece toric IOL was implanted into the bag and dialed into position. AC was washed and the wounds were hydrated and the pupil was constricted using pilocarpine. Let's understand how the single pass 4-throw technique works on this eye model. I pass the needle through the paracentesis, pass it through the proximal iris and the distal iris, and then externalize the needle through the opposite paracentesis. I use a hook-like instrument to create a loop and pull it out through the proximal paracentesis. Now the proximal end of the suture is passed through this loop 4 times and the distal and the proximal end are pulled in the opposite direction so that the loops pass inside and create a knot. So I began the procedure by creating extra paracentesis. The straight 90 proline was passed through this paracentesis and MST forceps was used to hold the edge of the iris so that the needle could be passed. Another side port was made for the MST forceps to pass. The iris edge was held using the MST forceps and a 27 gauge needle was passed through the iris. The straight needle was then railroaded out through the needle. Now to create the loop, the MST forceps was used to bring the distal end of the suture closer so the Kruger's hook could pass and bring out a loop through the proximal paracentesis. Now the suture was passed through this loop 4 times to create 4 throws. The distal and the proximal end of the sutures are pulled in the opposite direction. Thus a knot was created and the pupillary margin was brought close together. Now for the second suture, The side port was used to pass the straight needle through the iris tissue, and on the distal side, with the support of the MST forceps, the straight needle was passed through the edge of the iris and pulled out from the paracentesis. The loop was brought out through the proximal end using a microrhexis forceps, and the 4 throws were passed through the loop to create the knot, which would be passed inside by pulling the distal and the proximal end of the sutures. Once the knot is passed inside and tightened, the remaining ends of the suture are cut using micro scissors. The pupil size looked satisfactory. However, there was a large gap in the inferior part of the eye which would cause glare to the patient. So I planned one more knot using the same 4-throw technique so that the iris tissue would be better approximated inferiorly. The same steps were followed using the straight Prolene needle. Loop was created and brought out through the proximal end. 4 throws were made around this loop. The knot was slid inside, the extra ends cut, and now the iris was well approximated. The AC was cleared of viscoelastic. The side ports were well hydrated. Day 5 slit lamp image showed a well settled eye with a post-op vision of 6/9 unaided. Thus, a careful planning and execution led to a happy patient. Thank you.
Thank you, Vanishri. Dr. Prashant, I think you have some experience in iridoplasty. Please.
Yeah. Thank you. Vanishri, wonderful video, basically. Very nice videos. Yeah, for any pupil, basically, if you have a mydriasis as big as this, you should do pupilloplasty. That is a very loud and clear message, which I would also echo with you. And a wonderfully done surgery is beautiful.
Can I
think the best part was the way you showed in a diagrammatic manner how to do it, because when people show you surgically, then all the sutures kind of get confused and then you can't depict it. But I think this is one of the best diagrammatic representation of how to, an explanation of how to do it.
Ma'am, that was the idea actually. When I was editing the video, I realized who want to learn, the people who want to learn how to do pupilloplasty, it's very confusing when you see the surgical video directly. So that's why I made that model, and thank you.
Yeah, very nice video, Vanishri. I just wanted to compliment you for that.
Thank you, sir.
But the only thing is, if you have such a huge traumatic mydriasis, what I used to do a lot of SFTs, easy to do SFT, but only thing is multiple times you have to make sure. So I do the encerclage, which is actually like a purse string. So you can maintain the size of the pupil as well. It is more difficult than SFT. Only thing is the encerclage is also easy because it's on one side you go through. So it's every procedure there is a learning curve. But it is really hats off to you, and hats off to Amar for bringing this.
Thank you, sir.
One suggestion, like while doing this or while doing iododialysis repair, one alternate thing will be when you are making paracentesis, I think you will be having a posterior segment surgeon in your place. Posterior segment surgeons. Posterior segment we are surgeons.
Yes,
so you can borrow either a 23 or a 27 non-valved cannulas. When we put it into the paracentesis, the negotiation of the needle is very smooth, because in this sometimes it goes through the stroma of the, what do you call?
Yeah, that's called Naresh, the trocar assisted.
Yes.
We do the iododialysis repair as well.
That will be slightly easier actually.
Nice video. Just one query. Was there a subluxus and you put a CTR after the phaco was done?
It was more of a protective measure actually,
Okay,
because I didn't get any
prophylactic
subluxation, but
yeah.
since it was a history of trauma, as a safety factor.
Okay. Thank you.
Thank you. So 2 more videos to go. Next we call upon video number 10. We invite the Chief and Presenting Author, Dr. Sujit Nayanar, on stage. Please.
Hey Pooja, what are you working on?
So see how AI is clearing up this vascular cornea into a clear cornea. I wish there was some real life procedure to make this happen. Today I met a patient in OPD, blind in one eye for 28 years with total limbal stem cell deficiency. Hope we could do something like this to help her.
Actually, that's not AI magic, Pooja. In reality, SLET can give you results just like this.
Sir, are you sure?
Oh yes, thanks to Dr. Virendra Sangwan and his team. Come, let's plan SLET for this patient too.
Simple limbal epithelial transplantation. The specific phenotype of corneal epithelial cell is protected from the conjunctival epithelial cells by the limbus, which is situated at the junction of the cornea and conjunctiva. Limbus harbors the vital limbal stem cells. These cells reside within the palisades of Vogt, the specialized niches in a protected environment that constantly replenish the corneal surface and maintain its clarity. This forms a critical barrier preventing the conjunctival cells crossing over to the cornea. Damage to this delicate reservoir can occur from burns, multiple surgeries, chronic infections, inflammation, congenital or idiopathic diseases of ocular surface. Such damage leads to limbal stem cell deficiency, either partial or total deficiency, leading to a condition where the conjunctiva grows over the cornea, making it vascularized and opaque, ultimately affecting the vision. Restoring this stem cell population is the key to reversing blindness. Simple limbal epithelial transplantation or SLET, first described by Dr. Virendra Sangwan, offers a safe and innovative solution. The donor epithelial cells can be from healthy fellow eye in auto-SLET or from donor cadaveric eye in allo-SLET procedure. Here we demonstrate steps and outcome of an auto-SLET procedure performed in case of a 54-year-old female with 28 years of an untreated unilateral limbal stem cell deficiency. Preoperative ophthalmic workup should include an ultrasound B scan to rule out any hidden posterior segment pathology. Anterior segment or OCT imaging is vital in identifying the interface of conjunctival overgrowth and the thickness of residual corneal bed to avoid intraoperative surprises and chances of corneal perforation. The surgical journey begins with the meticulous removal of the deceased pannus, revealing a clear corneal surface ready for transformation. It needs a 360-degree peritomy in case of total LSCD. Excessive surface bleeding is expected in heavily vascularized cornea, which needs cautious cauterization. In some cases, the interface can be easily identified and the pannus can be peeled off smoothly. But in chronic cases like this, meticulous piecemeal dissection may be needed to achieve the targeted result. It is better to avoid sharp instruments for dissection so that unintentional superficial keratectomy can be avoided. Corneal tissue should be preserved at any cost to avoid thinning and perforation at a later stage. View of anterior chamber details and the pupil is a good guide during dissection. All fibrous tissue should be removed from the corneal surface. Bud polishing was performed for smoothing of the exposed surface of cornea, following which the magical amniotic membrane was applied onto the surface with fibrin glue. The membrane should be well ironed onto the surface and care should be taken to avoid redundant edges of membrane to prevent premature dislocation of the membrane by edge rolling. The donor tissue is dissected from superior 2 clock hours of healthy limbus of fellow eye in auto slit, taking due care not to disturb the donor limbal stem cells. The donor strip of limbus is then split into multiple small pieces, around 8 to 10, and placed equally spaced over the deceased cornea in the mid-periphery. Drops of fibrin glue is then applied over the tiny bits to keep them in place, followed by application of bandaged contact lens. Post-op medications include topical antibiotics, steroids and lubricants till new epithelium takes over. Transformation changes of corneal surface is seen over next few weeks to months, ultimately leading to clearing of cornea due to the restored limbal barrier at the periphery, which also prevents further ingrowth of conjunctiva.
Today has been a true learning experience. Every technique we master is another chance to give sight back to someone who had lost hope.
And it fills me with pride that we Indians pioneered Eslalite. It shows the world that innovation and compassion can truly go hand in hand.
We carry the responsibility of our patients' trust. They look at us with faith, even to take risks if it means giving vision back.
And while we push the limits of surgery, we must also walk hand in hand with technology. And yes, AI is not our replacement. It should be our companion, guiding us to better care in the future.
That's a very creative video from our upcoming scientific chairman, Ksos. So, Namrata Madam, Charles Sir, please comment.
The AI aspect was very good. AI, Sujit and Deepa look very nice.
No, I think the case was excellent and a case which would have been actually referred for corneal transplantation and failed because of the limbal stem cell deficiency, cleared well, the whole corneal transplantation was deferred and surgery was of course very meticulous, Sujit. You are a very meticulous surgeon. Kudos to you.
Thank you, ma'am.
This patient had blindness or corneal problem for the last 25 years, isn't it?
Yes, sir.
So what was the visual result? Should I have gone in for amblyopia?
No, no, sir. Actually, she was at that age. At that time, her age was in early 20s. The history goes like she was pregnant at that time, most probably some viral illness or something. But after the delivery, by that time, she lost her vision. And she has been going to many places for treatment. After a time, she stopped going. Now her son is a doctor in UK. So it was during his delivery that this has happened.
So you're famous internationally now.
Well done.
Next video, we don't have much time.
Sujit, I really have to compliment you for the wonderful way the video has been presented.
Yes.
The presentation was simply incredible.
Thank you.
Fantastic, the voice and the music and other things. I think we have to learn from this. Thank you.
It's a nice video. One non-scientific query. You were saying sharp instruments should be avoided. While your video was saying you were using Christian knife. So was it to confuse us? Or
No,
what?
no. Actually, it was a crescent knife only, but it was not a fresh crescent knife. It was used.
Yeah, you can use, and all the knives are not as sharp. So if you use, I mean, without any financial interest, if you use knives from the Indian companies, they're not as sharp as they are from.
Yes, yes.
And I think you did well, Sujit. Don't listen to it.
No. Crescent knife is not sharp normally.
No, actually, I specifically added that word because you should not go with the video, seeing that it should be sharp. So you should be using a blunt.
Yes, that was the point I wanted to hear from you. Thank you.
So the video award session, every video bettering the other with meticulous glossy, soulful animations. And we call upon the last video which made the cut. And as I call upon the last presenting author, I would like to reinstate what the scientific committee has had to say. All 30 plus videos that had been submitted were of excellent quality. And the scientific committee has specifically mentioned that some videos barely missed the cut by a fraction of a point. 0.1, 0.2 was the cutoff. All the other videos are available for viewing in the kiosk. So please take time to see the videos to appreciate the effort that has been taken. And I would like to invite the 7th video which has made it to the final session of Padma Shri Dr. S. Tony Fernandez Video Award session. Video number 14. We would like to call upon the Chief and Presenting Author, Dr. Anubhav Goyal, on stage. Please.
When the going gets tough. A 65 years male planned vitrectomy surgery for right eye rhegmatogenous retinal detachment.
The presenter is there.
After 3 months of stable retina and vision improvement, patient was planned for silicone oil removal. Postoperatively, retina was attached with stable vision of 6/18 and 10. Even a simple vitreoretina procedure like silicone oil removal should be done with utmost caution. Careless attempts can lead to disastrous outcomes. Step-by-step understanding of all surgeries including VR surgeries is mandatory for all budding surgeons. Luckily, in this case macula was not damaged. Thus, retina stability was achieved with good visual outcomes.
Thank you, Dr. Anubhav. I'm glad you made it, otherwise this would have been a disqualification. So any comments on this, and with that we'll conclude it finally.
Actually, we don't remove the silicone oil under air. Even if the last bubble of oil is there, it should be removed under the fluid only, because the oil is going to float. And it is easy to remove by manipulating so that you bring the oil to the port actually. So when you do this, because of its a viscosity of 1500 or 2000 or 5000, it's very difficult to aspirate. So I think FA shouldn't have been done with such a large bubble. That's what I felt. Yeah. Mike. Yeah.
Hello. Usually what I have seen, sir, after complete oil removal, there are some minimal small oil bubbles which remain. Correct. And they can create floaters in post-op period.
Right.
So just to remove that small oil missiles, we try to do that FAE just to take them out.
Correct.
So that was the attempt, and we found it, that small bubble, even after that bubble, it became a very big bubble while doing FAE.
Now I'll suggest one article for you from Japan, maybe 4 or 5 years ago.
Yeah.
They found that doing FAE versus passive removal, FAE causes more emulsified oil to remain inside the eyeball. I think I can give that article to you. Okay. So they don't suggest FAE for silicone oil removal.
Okay, sir.
Thank you.
So thank you, and thank you all the presenters and especially our judges for such wonderful interactive session. And I thank the audience for being here in such huge numbers. So while we finish, I'll just like to ask the scientific chairperson to conclude.
Yeah, thank you all the participants for your excellent videos, and all the judges. Thank you once again. The results will be announced along with the OPL today in this hall at 3:30 p.m. or during the general body. Thank you all. Please stay back for the important session next.